Good afternoon, everyone. I'm just going to wait just briefly to have a few people before we kick off with today's webinar. So let's just allow a few more attendees to log in, and then we'll start. Thank you.
It's Helen here. Our electricity just went back off and it's come back on.
Helen, I heard you and then you went off. Can you hear me?
I can hear you clearly. Can you hear me? Because the electricity's come back, but I don't know if I'm still fully connected.
We can hear you loud and clear, Helen.
Okay. That's fine. Thank you. That's great.
Thank you and good afternoon. I think we've got enough people now who have joined us, and I think we should get started. So thank you very much again, and thank you for joining us on our fifth installment of our webinar series that the NITEC Support Hub has been hosting. And as you very well know, this one is on malaria vaccine introduction in Africa. A lot of you would know that the 2015 Nobel Prize for Medicine and Physiology was awarded jointly to a number of people, but one of those was Tu Youyou from China for her work on artemisinin that basically changed the face of management of malaria in the world, potentially saving millions of lives in the African continent. But I think the awarding of that Nobel Prize underlies the importance of malaria in our continent. And so it's not a surprise to realize that the current webinar, which has been informed by the priorities that NITEC in Africa identified, is still high on the list where malaria needs to be dealt with. And I think this is a really great opportunity for us in this time where there is promise of doing something, not just treatment as what would have been indicated by the 2015 Nobel Prize, but rather by the potential of actually having a preventive tool that can actually make a big difference in the lives of the children and adults of this continent. And in particular, as we know that children, in terms of the burden of morbidity and mortality, carry the brunt of malaria, this is becoming even much more important for us. So I want to welcome you this afternoon to this webinar series, which is co-hosted by the NITEC Support Hub based in Cape Town, as well as the Ugandan NITEC that are the co-host for this afternoon's webinar series. As we start and kick off, I would just like to acknowledge the presence of Helen, who is the Right Tech Chair for Africa, as well as Elaine, who is based at WHO, the Malaria Vaccine Implementation Program. Thank you very much for making yourself available for this very important topic as the NITEX within our continent grapple with what the way forward should look like. I will just request the attendees, if you can, that when you look at your names, I've just been looking at the names and then about 37 now people attending, but it would be really useful if you can just rename yourself by putting in bracket perhaps the countries that you're coming from. That will make it much easier when questions come up and when discussions come up to just have an idea as to where people are coming from. Degratius, I can see your hand is up. I'm not sure if you are struggling with the language issue or whether there is any other technical issue that you want to raise your hand for. Deo Gracious, is that a hand for a question? Okay, I think I think that was probably by mistake. It came up and then it disappeared again. So I am going to just say welcome again, and please do not hesitate to raise questions either in the chat box as well as raising your hand for different people to be able to answer and respond to some of your questions. And I think I'll say I'll stop here and then just let us continue with Bernard, starting with the burden of malaria in Africa and the effectiveness of the current interventions against malaria. Thank you so much. I'm seeing two hands again. Are there any issues? Bernard, before you continue, I think you can share your screen, but I just want to check if there are any issues. There were two other hands. I just want to check if there are issues that we are missing here, that either people cannot hear as well. I think Salim, the people have mentioned about the chat being disabled, and we'll sort that out as we go, so that if you need to say anything, you can do so. Thank you so much.
Thank you so much for this introduction, and thank you so much for having us. So my name is Eliane Furrer. I'm from WHO. I'm a technical officer working in the malaria vaccines team within the immunization department. And I will deliver this first presentation together with my colleague, Dr. Magaiwa Magafu. He is the malaria vaccine focal point in the regional office in Brazzaville. And so he will start with the first couple of slides.
Thank you, the organizers and my colleague, Eliane, for the kind introduction and for having us. We are very much pleased to share information about the malaria vaccine at TSS. And so first things first, I'm going to start with the WHO recommendation on the use of the first malaria vaccine at TSS that was issued in October 2021. The details of the recommendations are given on this slide. WHO recommends the malaria vaccine be used for the prevention of P. falciparum malaria in children living in regions with moderate to high transmission as defined by WHO. The malaria vaccine should be provided in a schedule of 4 doses in the children starting from 5 months of age for the reduction of the malaria disease and burden. Secondly, the countries may consider providing the vaccine seasonally with a 5-dose strategy in areas with highly seasonal malaria or areas with perennial malaria transmission with seasonal peaks. The malaria vaccine introduction should be considered in the context of comprehensive national malaria control plans. So it's not a standalone intervention, but it has to be integrated with other interventions that are there to combat malaria in the countries. The right side of the screen, you see links, useful links that share a lot of information about the vaccine. We also have an ITAG Resource Center at the bottom there. And there's a link there that you could use to visit the website and have resources that are specific to the NITAG. Next slide. Now, further details on the recommendation for the broader use of the malaria vaccine. Regarding the schedule, the first dose is administered from 5 months of age, and there is a minimum interval of 5 weeks between doses. The primary series, there's a primary series of 3 doses. The 4th dose is given approximately 12 to 18 months after the 30 dose, and that is meant to prolong duration of protection. There is flexibility within the recommendation, and there is flexibility within the schedule to optimize delivery. As an example, to align the 4th dose with other vaccines in the 2nd year of life. So the interval is not written in stone. Children who begin their vaccination series should complete the 4-dose schedule for maximum protection. Now, optional schedule for settings with higher seasonal malaria or perennial malaria with seasonal peaks are available. 1, the seasonal vaccination to maximize impact by timing vaccination to the period of highest malaria transmission. That is the main purpose. Now, the primary 3-dose series is provided monthly, either from 5 months of age or just prior to the peak season. Additional doses are provided annually prior to the peak season, and that will make up to a total of 5 doses. Now, countries that choose to develop deployment of this seasonal strategy are strongly encouraged to document their experience. Next slide. Now, what are the product characteristics of the malaria vaccine RTSS, which has already been pre-qualified by WHO? It's an injectable vaccine, which is given intramuscularly, and it consists of 2 vials, which you see in the picture on the left side of the slide. Once reconstituted, the vial contains 2 doses of vaccine, which must be used within 6 hours or discarded at the end of the session, whichever comes first. In terms of shelf life, it's 36 months when it is stored at a temperature between 2 to 8 degrees centigrade. It's a freeze-sensitive and light-sensitive vaccine. The vaccine is a lyophil, and it's banded together with an adjuvant, which is a liquid, and they are color-coded. The adjuvant, the liquid adjuvant, has got a green ring, and the antigen itself, a lyophil, has got a red ring. So you can clearly identify them. Now, the vaccine contains a VVM, a vaccine vial monitor, and the package is convenient. You have 100 vials per pack, and that makes a volume of almost 9.92 centimeter cube per dose. And that doesn't really increase, much demand on the cold chain. In terms of co-administration, it can be given concomitantly with pentavalent, OPV, measles, rubella, yellow fever, rotavirus, and pneumococcal conjugate vaccine. If you need to know more about this, there's a link that you could use to visit the website that contains the information, and it's available there. You get more on the product information. Next slide. Now, the clinical trials for RTSS were conducted from 2009 to 2014, and that is specifically for phase 3 trials. Now, the efficacy results are captured on this slide against different endpoints. The key outcome for a 4-dose schedule among children first vaccinated at 5 to 17 months of age with 4 years of follow-up. There was a 39% reduction in clinical malaria, 29% reduction in severe malaria, 37% reduction in malaria hospitalization, 62% reduction in severe malaria anemia, and 29% reduction in the need for blood transfusion. I must say that the efficacy that is indicated here was achieved on top of the benefits that were provided by insecticide-treated bed nets. Now, modeling has shown that one life is saved for every 200 children who were vaccinated by RTSS. I should also note that the efficacy was lower in younger infants during the clinical trials, between 6 to 14 weeks. And therefore, the vaccine is not recommended in this age group. Next slide. Now, during the phase 3 clinical trial, the vaccine showed high impact, as you see, in different areas that the vaccine was tested. You see the localities in different countries there. There's Siaya in Kenya, there is Kintapo in Ghana, there is Lilongwe, Malawi, Bagamoyo, Tanzania, Korogwe, Kilifi, Mainka, and others. So across a range of areas on the continent, and the graph is showing on the right, on the y-axis, cases averted per 1,000 vaccinees. And the bars are comparing 3 doses against 4 doses. As you can see, regardless of the dose, the impact is very high, and the impact is actually determined by the intensity of the transmission of the disease. And the recommendation is actually also based on that. So thousands of clinical malaria cases were vetted over 4 years with 3 or 4 doses. Highest impact in moderate to high transmission areas. Next slide. Now, following the successful completion of the clinical trials, there were a few outstanding issues regarding the feasibility of administering the vaccine with a 4-dose schedule using the routine immunization system. There are also outstanding safety issues, and there was also a need of understanding the impact of the vaccine in a large population. So SAGE and MPAC recommended to WHO that phased pilot implementation of the vaccine be conducted, and it was eventually decided that the pilot be conducted in Ghana, Kenya, and Malawi. And so the pilot was designed to have vaccinating districts or counties for Kenya that are represented here in a green color, and to have comparator districts or counties that are represented here in a pinky color, and there are areas that are out of the MVP, and those are not shaded. Now, the implementation is started under the MVP in the vaccinating districts, the green ones, and that started in April 2019 in Malawi and Ghana. And then in Kenya, it started in September 2019. Now, after 2 years of implementation, the data were analyzed. Eliane will go into the details of the results. The data were analyzed, and these issues, feasibility, safety, and the impact were sorted out. And as a result, WHO issued the recommendation that I started with when I started this presentation. And so now that the vaccine has been recommended for broader use, broad use among countries, these countries have now expanded the use of the vaccine to comparator districts. And Malawi did that on the 29th of November last year. Ghana did it this year on the 20th of February, and Kenya did it on the 7th of March. So they have just started. Next slide, please. Now, how is the MVP progressing? The MVP has been progressing very well. Even during COVID pandemic, the vaccine coverage has been relatively good. And as you see here, from the time of the launch to date, up to mid-March, more than 4.1 million vaccine doses have been administered in the 3 countries. And more than 1.34 million children have received at least a dose in those countries. So that's the number of children that have been reached by the vaccine. Next slide, please. Now, if you look at the individual countries, Malawi, Ghana, and Kenya, Malawi on the top, Ghana in the middle, and then you have Kenya at the bottom. So you will see that the dotted red line is indicating the target population. And the green one is indicating the coverage for Penta 3. And the navy blue is RTSS 1, the light blue is RTSS 3, and the gold color solid measles rubella 1, and the broken gold color is measles rubella 2. And then there is what looks like a gray there, or light blue. You can see the pointer there. That is the 4th dose of RTSS. Now, for Malawi, you'll see that they started at a low point. They had a silent launch, and then they increased rapidly coverage. And at 18 months, the coverage of the first dose of RTSS was the same as that of Penta 3. And that was remarkable, again, pointing to the acceptability of the vaccine by caregivers as well as healthcare workers. And of course, if you consider the COVID-19 pandemic, you know, it speaks to the resilience of the health systems in these countries. There has been challenges, though. You see there the red dotted circle there. Tropical storm hitting, Malawi again hit by epidemics, outbreaks, cholera, as well as wild polio virus, again interfering with the normal routine immunization activities, and you see the coverage dipping. If you look at the for Ghana, you will see that it started at a high point, then they have maintained the more or less same coverage, except for a few challenges. There was a COVID-19 related stock out in 2020, and you see the pointer showing there. And then there was a stock out early this year, late last year. And that has caused a dipping in the coverage, as you see at the end of the curves. Now for Kenya started with what we call an expanded age of eligibility. So not only 6 months, which is when they give the first dose, but they went up to 12 months, 11 months through 11 months. And so in the end, you see, the coverage for RTS1, they are going beyond the target population. And then after that catch-up exercise ends, the coverage comes back to where it's expected to be, and then it's maintained. I must say that there have been, again, challenges in Kenya. They had healthcare worker strikes, which indicated by the dipping in coverage there. And then when that was sorted out, they did some catch up, and again, coverage went back to where it is. If you look at the left side, you see the tables there. They're comparing the averages for 2020 coverage, 2021 and 2022. You'll see that really there hasn't been much effect in terms of reduction in coverage. It's really well maintained despite the challenges that the countries have experienced, in particular the COVID-19 pandemic. And next slide. I will now call upon my colleague Edian to take us forward from here. Edian, please.
Thank you very much, Megaiwa. So I will now share some further findings from the pilot implementation program, especially the ones that were the basis for the WHO recommendation in October 2021. At that point in time, we had 2 years of evaluation data, looking at feasibility, safety, and impact. And we were able to summarize the data across the 3 countries and present those as the basis for recommendation, alongside the previous clinical studies and data, which are quite abundant for this vaccine. So in terms of feasibility, as Megaiwa mentioned just before, the vaccine introduction was found to be feasible with good uptake and coverage through the routine system. There were no negative impacts on the uptake of other vaccine or the use of bed nets or care-seeking behavior. And this was important to establish because there was some fear that maybe the presence of the vaccine could reduce the use of bed nets. And so we did not see that in the pilots. The safety was confirmed to be, the vaccine was confirmed to have a good safety profile. The safety signals that had previously been seen in the phase 3 trial were not identified, with over 3 million doses provided and a very robust evaluation conducted. So we can now say that the safety of this vaccine is confirmed. In terms of impact, the vaccine introduction at the population level resulted in a substantial reduction in severe malaria and all-cause mortality in children that are age eligible to receive the vaccine. Even in settings where the ITN use was already quite high and access to care relatively good. We measured a 32% reduction in hospitalized severe malaria. And this, remember, this is in a routine implementation setting. So as Megaiwa showed, at that point in time, we had roughly 60 to 70% vaccination coverage for the first 3 doses. And in that environment, we were able to measure a 32% reduction in hospitalized severe malaria, which is quite remarkable. The data collection has continued following the 24-month analysis and is actually coming to a completion this year. So we will have further results concerning the all-cause mortality after additional months of follow-up. And then an important point on equity, the vaccine was found to be reaching children who are not using some other forms of prevention against malaria, such as ITNs, increasing the access overall to malaria prevention tools to over 90%. And I would like to illustrate this point on a subsequent slide. So this slide is showing that how adding a malaria vaccine to current intervention can increase access and reduces the gaps in malaria prevention tool. So this graphic shows the results from a household survey conducted in Ghana in the areas where the pilot was implemented. You can see there are 69% of the children in that household survey used an ITN, a bed net. And in terms of vaccination, there were 77% of the children in the household survey that were vaccinated with the first dose of RTSS. But interestingly, you can see that not all of these children are the same. There is an overlap of 55% children that used both an ITN and were vaccinated. But there were also some children that were not using an ITN, but that did get access to the vaccine. And then on the other side here, there were some children that were reached with an ITN, but did not get vaccinated. But overall, you can see by adding an additional intervention that uses a different delivery channel, the 3 countries were able to expand the access to a malaria prevention intervention to up to 90%. And that's really quite remarkable. Now, of course, the challenge is to make sure that those not yet reached with a vaccine also get it, and those who have access to none of the interventions are also included. Then one of the partners in the pilot implementation is PATH, and they were responsible for conducting a qualitative study that ran alongside the pilot evaluation, and also undertaking costing studies and cost effectiveness studies. The qualitative study also confirmed that the vaccine is acceptable both to health service providers and the target population. They were able to establish through this qualitative research an increase in trust that facilitated vaccine uptake. Initially, the parents reported trust in the health system and vaccines in general, and later, over time, this specific trust in the malaria vaccine increased, probably through more exposure and more experience in the communities. In terms of the additional financial resources requirements, it does have an additional cost and burden, but it's broadly comparable with other new vaccines recently introduced in the routine program. At the initial vaccine price at $10 per dose, and I'll speak a little bit more about this later, even at this price, a 4-dose schedule was confirmed to remain cost-effective for perennial transmission settings that have more than 10% parasite prevalence. So these are usually moderate to high transmission settings, with a cost of $150 to $200 per daily averted. And they also did some preliminary analysis of the cost effectiveness in highly seasonal settings, and confirmed that the cost effectiveness remains. Of course, the affordability at the country level is highly driven and influenced by the Gavi co-financing requirements. And I'll talk about this in a second. The modeling was updated with or reviewed based on the pilot findings, and they also continued to show a significant public health impact across a wide range of transmission settings. This slide just shows some findings from another phase 3 trial that was conducted in highly seasonal settings in Burkina Faso and Mali. And this was essentially the basis for the WHO, part of the WHO recommendation that enables also a seasonal delivery using a 5-dose schedule. And what you can see here is the efficacy numbers, the combined efficacy of adding the vaccine alongside seasonal malaria chemoprevention interventions. And there were a couple of important findings. First of all, the vaccine was shown to be non-inferior to 4 rounds of seasonal malaria chemoprevention in protecting against clinical malaria. And this was important because from other studies, we know that SMC is highly efficacious, preventing up to 75% of clinical and severe malaria cases. And so in this trial, the vaccine was shown to be non-inferior to that well-established interventions when provided in a seasonal way, meaning vaccine administration is timed to occur just before the malaria transmission season. And then another interesting finding was that adding the 2 intervention, whereby first the vaccine is administered prior to the transmission season and then SMC rounds are conducted, there is a combined increased efficacy that you can see here in these numbers. And then just a few words on the next steps. So this is the final year of the MVIP, the pilot evaluation. Of course, the vaccination has been going on and will continue beyond that date because it's a routine implementation in the 3 countries. But in terms of the evaluation, this is coming to an end this year. And one of the big priorities for the WHO team and partners is to really make sure that we document and disseminate the results and the lessons learned. For example, we are in the process of finalizing a vaccine introduction guide and related tools to really capture the lessons and provide more operational details on the WHO recommendation. We are also planning a number of publications to document the pilot evaluation results, the framework for policy decision, the framework for supply allocation and other lessons learned. And then we really hope to be able to support cross-country engagements with ministries of health and partners and bringing in the pilot countries who have really learned or showed a lot of interesting learnings and experiences through their almost 4 years of implementation now. Then just a word on the available support from Gavi, the Vaccine Alliance. Shortly after the WHO recommendation became available at the end of 2021, Gavi looked at a malaria vaccine investment case and approved a new support for malaria vaccine. So this means now in practice that Gavi eligible countries can apply to Gavi for malaria vaccine support for introduction into the routine immunization schedules in areas of moderate to high P. falciparum malaria transmission. So this aligns with the scope of the WHO recommendation. The Gavi support covers vaccine support and, as usual, injection supplies, as well as some financial support to facilitate the introduction and some technical assistance support. As for any other new vaccine supported by Gavi, a co-financing policy applies, which means that countries need to contribute to the cost of the vaccine based on their income level. There's 3 co-financing groupings. But exceptionally for this vaccine, recognizing that the initial price is quite high, Gavi approved a time-limited revised approach with slightly more favorable terms in order to facilitate affordability and uptake. Gavi reports or confirms what we've seen for a couple of months now, that there is really a very high level of demand from countries in the African region. More than 28 countries have expressed interest to introduce the vaccine in the near future, and many have already taken advantage of the first application windows. There was a first window opened in September. This was dedicated to the 3 pilot countries in order to allow them to apply for vaccine support to continue vaccination in the pilot areas, so in areas where these services have already been in place. And there was a second application window that closed in January. There were 11 applications recommended for approval based on this first submission, which is quite remarkable, and again showing the huge level of interest. The next step for these new applications is now the supply allocation, and Professor Helen Rees will talk a little bit more about that in a bit. And then there's subsequent application windows this year. One will close in a couple of days, and then another one in July and October, where additional countries can apply for support. Then this is my final slide to just give a bit of an outlook about the malaria vaccine supply situation. So currently there is one vaccine recommended for use and pre-qualified. This is the RTS AS01 vaccine produced by GSK. The initial price has been established at 9.3 euros per dose. We would expect this price to come down over time. The relatively high price is linked to low production volumes. There is a limited capacity at the moment in the existing facility, and UNICEF was able to secure a first supply contract of 18 million doses for this year, 6 next year, and 8 million in 2025. So quite limited supply situation. And the allocation will be done based on the framework for allocation of limited supply that Professor Rees will talk about. The outlook for the medium to long term is as follows. There are basically 2 avenues to potentially have more supply. And I should say this is a big priority for the Gavi Alliance, as well as for WHO and UNICEF and other partners to really work on this supply situation. The first avenue is for the RTSS to be transferred to Bharat Biotech. This is an effort that is underway at the moment. And the expectation is that once Bharat Biotech takes over the production of RTSS, the capacity will increase and we would hopefully have more product available. This will take a couple of years to be completed entirely. Then the second potential avenue is if an additional malaria vaccine becomes available in the market. And as you know, we always want to have more than one product in the market in order to reduce the price, but also have more supply security. So there is a candidate, R21 Matrix M, that is currently in phase 3 clinical trials. WHO has started to review the data related to this vaccine. The trials are not quite finished yet, so we haven't seen the full data set yet, but a working group has started to look at this. And so this could potentially lead to a future recommendation for use. And then, as I mentioned, the price is expected to come down with more supply and scale up of production. You have here a couple of useful links if you're interested in more details about price, supply, or market shaping efforts. And with this, so this completes our first session. I know that Professor Rees has to leave at some point, so we would have her slides ready as well.
Yes, thank you very much. If we could put up my slides. Thank you very much, and good morning, good afternoon to everybody. So I'm now going to go to sort of the next step. You've already seen that there's a shortage of malaria vaccines over the next 3 years. And so how did we consider prioritizing how to distribute those vaccines? I'm going to describe how the framework was developed. So just to restate, there are over 25 million children born each year in regions with moderate to high malaria transmission. And over 28 countries, as you just heard, have already expressed interest in introducing the vaccine. This is a vaccine that's creating huge excitement in affected countries. That, however, means that the demand is between 80 to 100 million doses per year. But the supply, as you've just seen, is only 18 million doses between 2023 and 2025. Next slide. So WHO was asked to consider how we should develop a mechanism to allocate the available vaccine doses. And to do this, they set up a working group that I'll describe to you later. The sort of questions that the working group had to consider with WHO is, do we give the available vaccines to the first countries who are ready to take them, or to the countries with the highest burden? Or to those countries that are most likely to achieve the best outcome. So, for example, countries with good essential vaccination coverage. Or to the countries that participated in the clinical development of the vaccine, or to a combination of all of those. And what we did was we learned a little bit here also from experience with COVID-19 vaccines, and we started off with an ethics approval. In the ethics, we have an ethics committee that we asked to consider this and give us some ethical guidance as a starting point. And this were a couple of the quotes from their document. Science and/or evidence alone cannot tell us which choice or aim is correct or which aim society should value the most. Consequently, the first step in developing a framework for the allocation of scarce resources requires explicit consideration and clarification of ethical values. Next slide. So here we have the framework for the allocation of the malaria vaccines. And this describes the process that we went about to develop the framework. So it started in January of 2022. And as I say, an expert working group was established, which had experts on it from the RITAG, SAGE, the malaria programs, and the WHO Act Accelerator, plus the ethics working group I've just referred to. So a very mixed set of skills that were looking at this. These advisors had several meetings to develop, first of all, a draft framework, and that was by about March of last year. With the draft framework, there were then extensive stakeholder consultations. And that included quite possibly some of you who are listening to this, because it included NITAG members, EPI, the Ministers of Health, civil society, community organizations, but also global health stakeholders such as SAGE, MPAG, and the Afro-RITAG as well. And then we had a fourth advisors meeting and put together all the comments that had been received, and then revised the framework. And that framework was then offered for approval and endorsed by the WHO DG. Next slide. These are the members of this committee. I'm sure if you scan down there, you'll see a number of people whose names you recognize, but you can also see the variety of skills and backgrounds and structures that the members of this committee were drawn from. I was the co-chair and delighted to co-chair with my colleague, Professor Rose Leakey, who I'm sure many of you know from her work in Cameroon, but also her regional and global work. Next slide. So this gives you a sense in one slide of what the framework for the allocation looked like. First of all, there were governance principles of transparency, inclusiveness, and participation and accountability. And you'll note that when we had that first draft of this framework, we straight away went to a whole group of several different groups of people where we had consultations so that we could get people's viewpoints from different perspectives, including in the region. The other foundational value at the end, the red one underneath, was what's called solidarity. And this became, you'll see, as this became a very important principle as the framework was applied. So instead of thinking about what I need as an individual country, the idea was to say there's solidarity with countries most in need. So we think as a community and we stand in solidarity with those most in need. And initially, if there were going to be unmet vaccine requests for the greatest need, category 1, which I'll describe to you now across multiple countries, no single country should receive more than 20% of the total available supply. You can imagine that, for example, a large country like DR Congo that has a significant burden of disease, that had they applied early and we'd had a first come, first served approach, we could have used much of the supply, but for one country. So this idea of solidarity was that countries stand side by side with each other. In terms of the ethical principles, an important one, that first priority was looking at who has the greatest need and how do we define that? The first priority principle was to allocate the vaccine to countries with areas of the greatest need, where the malaria disease burden in children and the risk of death is highest. The second priority I'll just mention, because that was used subsequently, was to maximize health impact. This meant to allocate the vaccine to countries or to sub-national levels in countries for use in areas where the expected health impact is greatest. And the question, of course, is how would you define that? In terms of the additional key considerations, there was a strong feeling that we had to honor our commitment to the MVIP countries, those that you've just heard about, who did the implementation programs, so that they do not, they who have had a vaccine don't suddenly stop having a vaccine, and they continue to get priority access. And in addition, to ensure continuity and sustainability of access to a vaccine once the program has started, we recognize that it would be very damaging to a program to start something with enthusiasm, both from political leadership and communities, and then to stop it. So continuity was seen as a priority. Next slide. If we break down, how are we going to measure greatest need? And so we came up with a way to do this. So we suggested we should allocate the vaccine to countries with areas of the greatest need, which was defined as where the malaria disease burden in children and the risk of death are the highest. And in order to do that, we defined that by saying, let's look at a composite index, putting these two things together, where we look at the prevalence rate in children and the under 5 all-cause mortality using the best available local data. Next slide. To show you what this would look like in a map of our region, I should also mention that it was noted that the big burden of disease is in the African region, but there are other countries such as India that also have a burden of disease, and that also has to be taken into consideration. But for the African region here, you can see that if we look at the prevalence rate and then we look at the all-cause mortality and we combine those together, we start to get a sense of where is the greatest need. Next slide. And we broke this down into 5 categories, and the purple is the greatest need. With the intention of saying this should be the first priority for allocation of limited numbers of vaccines in the next few years. And you can see that in the greatest need category, there were 3 groups, those either with a very high prevalence rate of 20 to 40 or over 40 in 2 cases, combined with a high under 5 all-cause mortality. And there were 3 categories there. And that gave us a sense of the category 1. Then there's obviously category 2, 3, 4, and 5, which over time, as we get more vaccines, would also then be considered. But it also gave countries an opportunity to see really where their hotspots are at a subnational level. Next slide. So if we look at where we were initially recommending the vaccines, where we got moderate to high transmission, we'll take this as an example of Burundi. So first of all, the country needed to identify those areas of high and moderate to high transmission where we're going to recommend the vaccine. And then we're looking at the categories of need as I've just described to you. And if you go to the map on the right, you can see there that there's a large areas with category 1 need. This is the highest need that I've just described to you. And so these will be eligible for the first phase of vaccine introduction. But in some cases, as I'll show you, even that was going to be too much vaccine for one country, going back to our solidarity principle of limiting each country to 1 million doses. So how would the country then go further? And the country was then suggested to look at other local factors, and we'll come back to that would help them further refine the subnational areas that would be targeted. Next slide. So if we look at a bigger picture of the countries that are in need with the solidarity cap, you can see that the bigger countries with the large populations where they've got high priority areas, that category 1 in purple, these would be affected by the solidarity cap. That means that these were the countries, Burkina Faso, Burundi with a blue star, Burkina Faso, Burundi, Cameroon, DR Congo, Mozambique, and Niger. These are the countries where if you look at what they would require in terms of numbers of vaccines using this category 1 approach, then they wouldn't have enough vaccines with the solidarity cap of 1 million to be able to get there. And they had to make further choices. Next slide. Just to look at two examples of how this then worked. In Liberia, they did this stratification, and they found that there were about 45,000 infants that would be eligible in 48 districts. And that would mean that would they have enough vaccines to then supply with the cap of 1 million, all of those children with 4 vaccines? And the answer would be yes. But if we go to the next slide, you can see here that if we look at Cameroon, they would require 1.7 million doses a year to cover all of the children in their category 1 districts. And that would exceed the solidarity cap of 1 million doses. So a country like Cameroon then had to do further stratification within districts or sub-districts. Next slide. And this further prioritization to look at these category 1s were based on the country's own criteria, which included consideration of essential immunization coverage. Next slide. So in this case, the second priority principle, which, you remember, our ethical principles for allocation, was then taken into account. And this, if to remind us, said, where are we going to get maximum health impact? That's to say, given that further prioritization has to occur within a country, we then need to consider allocating the vaccines to, in this case, subnational areas for use in areas where the expected health impact is the greatest. And so this principle was applied, and a proxy measure for this was then looking at essential immunization coverage. And two things could be looked at if the country chose to do this, which was the dropout rate between the 3rd dose of DTP3 and the 1st dose of MCV1. And countries, or in this case, the sub-regional, subnational rather, areas which had the lowest dropout rate, i.e. the most successful immunization program, were ranked higher. And the idea here is that if you're going to get maximum benefit and limited numbers of vaccines, go to an area where the immunization program is working well, because then you're very likely to save more lives with that approach. Next slide. So just to sort of summarize, and obviously we're happy to discuss this further, what was clear with the limited number of vaccines that we have is that interested countries were not guaranteed to be able to access the malaria vaccine during this initial period of rollout because of these supply constraints. And the goal of this framework was to ensure that the allocation of these supplies adhered to values and principles of solidarity, of greatest need, of impact, and of equity. We proposed, in addition, that all countries should consider a phased approach to vaccine implementation, starting in areas with highest need, with expansion after the supply increases. It's important to manage expectations. Clearly, we've heard that 28 countries have approached Gavi already from the African region, enthusiastic to get access to vaccines. So for that reason, it's very important to have discussions like this, in fact, where we explain what the framework is, how it was consulted on, how it was developed, and have really good communication between the suppliers, between WHO and with countries. But this framework isn't static. And as we see how it works, and as we get more vaccines, we'll be able to support prioritizations, decisions at the start and as supply increases. And the framework will undergo periodic review and updates. And once again, those principles which included communication and transparency would apply as those reviews are taken. Thank you very much.
Thank you so much, Helen, and to Eliane and to Mugawa for excellent presentations. I think now we're going to hand over to Celia from Unitag to take us through the discussion. And if Celia, we could first take questions directed to Helen because she'll be leaving soon. That would be excellent. Thank you.
Okay, thank you very much, Ben, and thank you to the discussants and the presenters. There's no question to Helen in the chat right now, but if you'd like to put one, please, you're welcome. I know that some countries have already submitted their applications, and I would be interested to hear from them how they went about the allocation. We have some people from some of the priority countries. If you'd like to share your experience, you could just put up your hand and we can take that. I know that Uganda, we're in the process of doing that, so we haven't completed our work. But Benjamin, if you want to say something, please go ahead.
Yeah, maybe I can ask a question to Helen in terms of one of the priorities for the framework, which is maximizing the health impact of the vaccine. So Helen, for the countries that are getting funded to introduce the vaccine, I'm wondering whether there is a plan with specific indicators for the impact evaluation of the vaccine. This is post-introduction. Thank you.
Well, I'm sure that, excuse me, my colleagues from WHO would be well placed to answer this, but there certainly will be, because I think there's going to be huge interest in the impact at a population level of the introduction, including, and it's going to continue to be a question, whether there's any negative or indeed positive impact on the use of other malaria prevention measures, but also on the uptake of other vaccines. So there will definitely be feedback and evaluation. And like all things, you don't know if this is going to go according to plan. We don't know for sure whether demand will be similar across different countries. So far, the indications are that it would be at a population level. So I think the answer to your question is yes, there will be evaluation of monitoring and evaluation of uptake and impact. And perhaps the other WHO colleagues would like to comment on that.
Thanks, Helen. Here, if I may come in, as I mentioned, the pilot evaluation is in a way one of the largest scale implementation, pilot implementation of a new vaccine that I think we've ever seen, and it comes with a very robust evaluation of impact in the real life setting, and we have used the 24-month data for the policy recommendation, but we have continued data collection, and we will be publishing further data results at the end of the pilot. So we're getting to the end this year, and the results of the full pilot evaluation will be available hopefully in 2024. And so that will include the findings on impact in terms of reduction of severe malaria hospitalization and impact on all-cause mortality, where we saw initial trends after 2 years, but we hope to have further confirmation of that when the vaccine has been used for a longer period of time. And of course, each country is encouraged to also, as vaccine is being rolled out, to document the learnings and perhaps conduct further studies as appropriate. As we mentioned, we now have quite a lot of experience with vaccine introduction in perennial settings using a 4-dose schedule, where we lack experience in a real life setting, let's say, is the seasonal use of the vaccine that might be appropriate for areas that have highly seasonal malaria transmission. And so this would be an area where I think further implementation research would be of huge value among the first countries that will have access to the vaccine, and if they choose to use a seasonal timed approach.
Yes, Ruzani?
So this is just an area of interest for me, given the current level of vaccine efficacy. Is there any kind of system in place? For example, when we're looking at other vaccines on advanced phase, for example, R21, I'm just giving an example, right? If another vaccine should become available over the next year or so, coming into the market, which may have a higher efficacy, do we have kind of a system in place in terms of advice of how we're going to then have to deal with another product coming into the market? I know it's much easier if you think there's only one vaccine in place, but we know this is the first one and its efficacy may be slightly lower than what may be potential going to the future. Does that make sense, Elian? Yeah.
Yes, yeah, that's a very good question, actually. And we're starting to get more and more of this type of questions now with the potential of a second malaria vaccine being reviewed and potentially recommended. And I think it's, first of all, it's we don't have a head-to-head comparison trial for more than one vaccine. At this point, it, I think, would almost not be ethical to do so, because we have a recommended vaccine and then others in clinical development. So each of these new candidate vaccines will have trial results that are not directly comparing with RTSS. And there are a lot of factors that may be different. So I think any interpretation of efficacy data in particular has to be made with a lot of caution, because maybe just to highlight a few of the dimensions that are different. First of all, there will likely be differences in the transmission settings. We already see, for example, the RTSS vaccine phase 3 trials were done in a range of transmission settings, but including, for example, moderate and very high transmission settings. R21 has another set of transmission settings, but at the moment there is no high transmission setting included. So the baseline characteristics of the areas might be different. Then also the time of follow-up might be different, and other underlying characteristics like seasonality, the timing of vaccine administration, the duration of follow-up. And so I think going forward, we need to be very careful in the interpretation. And we actually had a recent update that we gave to SAGE a couple of weeks ago. And one of the messages there was already that, you know, we should be careful in comparing, for example, R21 directly with RTSS because of these underlying differences in the trial settings and time of follow-up and so on.
Yeah, sure. I mean, we had a similar consideration for the COVID-19 vaccine. Daniel, you have your hand up. Please come in.
Thank you very much. Good afternoon, everyone. And thank you, Polly, for the good presentation. I just have two small questions. One is the vaccine is banded with the age. Of course, they have set the minimum age for starting, and then you go through the 4 doses. But the scenario of malaria has no concern with the age. Even in the adult teenage, you can get attacked with malaria. So what is your constellation on that? Talking about the limited age, you have did the trial, and then the disease can affect even a person out of the age being highlighted. That's one. But also, the second part is this vaccination, if you have the 4 doses vaccination, it means that you are full vaccinated throughout your life, or maybe some further study might come out to assess if this vaccine is permanent. Thank you very much.
All right, thank you, Daniel. You are asking about the demand once the vaccine becomes available. Some more people outside the age range will ask to receive the vaccine as well, because it's such a cross-cutting problem across our population. I'll ask Elaine, you want to answer that? Why did we choose that age group and not the others?
Yes, I can start, and maybe my colleague, Dr. Magafu, may want to complement. So the developers, I think, choose this age range because that's where the burden is highest, and the risk of severe malaria and the risk of death being highest in those young children and children under 5. So the vaccine was specifically developed with the children in mind. Ideally, I would agree, we would have a vaccine that is available for the entire population, because transmission, of course, occurs in all age groups. But the initial focus of vaccine development was on the children where the burden is highest. Yeah, let me see if MacGyver.
I think, Elaine, you can take that with the concern about the waning immunity and the potential for a shift in the burden to the older age group after vaccination.
The shift in Cecilia, it's a little bit hard to hear you. I don't know if it's just me or, but if I correctly understand, the question is about waning of protection and whether there is an age shift in the disease burden among children who have been vaccinated, who may develop disease, more severe disease later on in life. Is that the question?
Yes, that's the question.
Okay, I see MacGyver has his hand up. Let me see if he wants to take that question.
Thank you, Elian. Starting with the first one, I think about the age. I think you have answered it very well. That we're targeting under 5s because they bear the brunt of the disease. They're the ones that are catching the disease the most. They're the ones who are dying the most, and in particular on the African continent. And so the vaccine was developed with those children in mind. Vaccines are developed like that. We have an example of COVID. You know, we started with certain age groups, adults, and then with the time, the vaccines that were developed were accepted for adults. Were tested in, you know, younger groups, and eventually they were found to work in those groups, and they were recommended, and they are in use at the moment. There was also a question from the same questioner that once you receive 4 doses, do you get lifelong immunity? The answer is no, you don't get lifelong immunity. The immunity wanes. And again, you know, that takes us to the point of targeting the group that is most vulnerable, taking them through that time period when they are most vulnerable to the disease. And so within if a child completes, you know, the 4, you know, doses, primary 3 doses plus another dose, 4 doses, that one should be able to take them through the most dangerous period of their life, below 5 years. And again, this has to be in the context of other malaria prevention measures, not only the vaccine. We are emphasizing this, and we continue asking the NITAGs to take the same message to the ministries, and you know, wherever and whenever you have an opportunity to share information about the vaccine. So there is waning. That's true, waning of immunity. But again, it takes a child through, you know, this most dangerous period of their life, and get into another age where they are less susceptible. Rebound malaria. with 4 doses, we don't see, that phenomena of rebound malaria, and so this should not be a concern to the NITAGs and the ministries.
Okay, thank you, Mugafo. There's a question for Dr. Helen. I don't know if she's gone away. From Nigeria, regarding countries with huge populations compared to others, and the fairness of the solidarity principle of receiving a minimum of 1 million doses. Is Helen still on? If not, maybe someone from WHO can take that on.
Yeah, I can.
Idris.
I can try. Thanks. It is very difficult, right? As Professor Lee said, there were many different ways and approaches that this could have been done, and the cap of 1 million doses was really put in place in order to enable a larger number of countries initially to get access to at least some vaccine supply, recognizing that in no country this would be enough to cover the highest burden areas. As she illustrated, there are a number of countries that would have many more children living in these highest need areas, in category 1 areas, and that will not be able to cover them all in the beginning. And it's clear that at some level this cap had to be established in order to allow more countries to benefit from that. I think the thing that was important for the expert advisors was to say that a child in this high burden, high need setting should be treated equally, whether this child is born in Benin or in Nigeria or in Senegal. And that from this point of view, a cap seemed to be reasonable. So in order to allow more countries across these high burden areas to get initial access, I think we have to admit no system is perfect, and no different ways of doing this may seem to favor certain settings, but I think really the desire was to treat the children in similar settings as equal as possible. And then the big problem is really that we don't have enough supply. No matter how fair the allocation is, we are running out of doses at some point. And so I think that just underlines the importance of efforts to increase supply, to signal to the manufacturers that more supply is needed and demanded. And I think we have some avenues where that could happen, but of course more efforts need to go into that.
All right, thanks, Elaine. There's two related questions. One regarding the demand for vaccine in pregnant women, if there's some research going on with that, as they're also at high risk. And the other one is what is being done to boost supply. All those are related to the limited demand, the limited supply and the high demand. Dr. Mugavu?
Yeah, I will respond. I have actually already responded in the chat box about the use of the vaccine in pregnant women. The vaccine, as I said, was developed to target children under 5. And so it has just been recommended for that group of children. It has not been tested among pregnant women yet. And so we do not know the safety profile of the vaccine in that group, of people. That has to be done first. So as of now, the short answer is that this vaccine is not recommended for use in pregnant women. Only under 5 children, of the ages that are specified by the EPI program of a specific country. guided by the WHO recommendation. Concerning supply, Eliane could come in. She's a specialist for this. We, following recommendation, Gavi, WHO, and partners activated market shaping mechanisms to try to increase the supply of the vaccine. Clearly, as you have seen and heard, the demand far outstrips the supply that is available, and hence the need of the framework. Now, those market shaping mechanisms that have been activated include the transfer of technology from the manufacturer, GSK at the moment, of RTSS, to an India-based company called Bharat Biotechnology. The process of transferring technology for the antigen RTSS is ongoing. We hope that once Bharat is able to produce the antigen there in India, that the amount that will be produced will increase and the price will go down. The other mechanism, part of that mechanism, is to, you have heard about local manufacturing. There is a huge political will of manufacturing the vaccine on the continent. It's a high-level discussion at the moment, but we also hope that once the vaccine gets to be manufactured on the continent, then that will help to increase the supply and bring down the price. And the other one, which has already been discussed, is the addition of new antigens on the market, new vaccines on the market. R21 is the most advanced that we have at the moment, and we pray for this vaccine to succeed. And we've been told by the developers that they will be able to manufacture it in large quantities, quickly, and that will increase the supply of the malaria vaccine to try and match the demand for the malaria vaccine. And so there are other, candidates that are in low phases of development, many, but we have R21, which is the most advanced. Eliane, anything that you would like to add?
No, I think you covered it well, MacGyver. Maybe just to add that it's really a very positive development that Gavi has opened the malaria vaccine program, because that program is not restricted to RTSS, but it could accommodate other vaccines once they are recommended by WHO and pre-qualified. So, for example, if R21 was to be recommended in the future, that would almost automatically be integrated in the Gavi support program. And so that would enable countries to have the choice between two products and hopefully more supply. And with competition in the market and larger production volumes, hopefully we would also see a price decrease. And so the engagement of Gavi means that all their market shaping experience and attention is coming into effect now. They have developed what they call a roadmap for the malaria vaccine market, where they document what the current issues are and what the objectives are that they want to pursue in this particular malaria vaccine market. And that includes as a high priority to foster increased production and decreases in price. So there is attention on this topic by different partners. Yeah. And I think one very good thing that we have seen over the last couple of months is this expression of demand by a lot of countries in the region, and supported also through the NITAG recommendations that signal to manufacturers that there is actual demand for a malaria vaccine with this profile. And that, I think, is the best encouragement to increase production levels.
Yes, fantastic. And we hope that will have a knock-on effect on the overall routine immunization program. There's one question on the immunity of the RTSS. Margaret is wondering if natural immunity has an impact on the efficacy of the vaccine. Dr. Mugafo?
Thank you for the question, Margaret. If you remember on one of my slides, I said that the vaccine is not recommended in the children, 6 weeks to 14 weeks. That's the reason why this vaccine is not given within that range of age when other antigens are given, the majority of the antigens are given. And one of the reasons is that children at that time, they have maternal, they could be having maternal antibodies that interfere with the response, immune response to the vaccine. So yes, there is, if you look at it from some angle, there is some interference, and we know for sure there is that interference in small children. That's why we give it in, children, of older age, so that either there's no that interference or it's minimized. I hope I've addressed that question.
Yes, she's also wondering if natural infection has an impact if somebody gets exposed to the infection of the pathogen later in life.
Impact on immunity?
Yes, impact of on the vaccine, of immunity of the vaccine. Does it increase with infection of the pathogen of malaria?
I think that one has not been assessed to the best of my knowledge, but I think it's a good question to think of. Yeah, there could be some extent, to some extent. Yeah, because if you have antigens, you have some level of antibodies, or memory of the infection, and therefore when you're exposed to an antigen, the body is stimulated to produce antibodies against the antigen that you were exposed to previously. And so theoretically that should be there, an effect should be there, but we have not seen an effect that makes the vaccine useless. That's what I should say. The vaccine still works.
All right. Elaine, could you translate Audrey's question, please?
Let me see. Yeah. So a colleague from DR Congo indicates that in DR Congo, the introduction of the vaccine against malaria will take place in 38 health zones out of the 519 and expected in 2024 as a result of the low production and limited availability on the international market. From today, how many years? How many years will it take to increase production of this vaccine in order to be able to extend vaccine use to all districts in the country? That again is a very good question, and difficult at this point, a little bit difficult to ascertain with precision. As I mentioned, this depends on two key factors: how quickly the RTSS vaccine can be transferred to Bharat Biotech. There are efforts underway to speed up the process. But as you can imagine, it's transferring a component of the vaccine to a new manufacturer also includes regulatory steps to make sure that the vaccine is produced in the same way and has the same quality and characteristics. And so that may take a few years. And the market studies that were done suggest that full supply could be available by sometime 26, 27 timeframe. However, I think the other area of uncertainty is whether the R21 vaccine can be recommended for use and how quickly that might be the case. As I mentioned, this is a promising vaccine. It's in phase 3 clinical trial, and WHO started to review the data that has been submitted so far. I would say in the best of all cases, if vaccine safety, efficacy, some duration of protection can be confirmed, there might be scope to have a recommendation in the near future where more vaccine supply through this channel could be available. I think in one of the best scenarios, potentially as early as 2024. And I think it's this combination of uncertainty, but also hope for certain scenarios that lead, for example, Gavi to not discourage countries from applying right now, even though we will not have enough supply to immediately allocate something to all countries that are approved by Gavi. There is still a scenario where we may get more supply starting in 2024. And therefore, at this point in time, Gavi still has application windows open for new countries to apply, get through the process of the independent review committee assessment. And then if at that point we don't have immediately supply available, countries would be on a waiting list. But as I mentioned, there are certain scenarios where we would have more supply potentially starting in 24. And so hopefully the waiting time would not be too long.
Okay, fingers crossed over that. And do we have any more questions from the audience? Otherwise, we will go to the next session.
Celia, if I may, I realize I may have not addressed one of the questions properly from regarding Nigeria. There was a question about how should a country with such a big need handle such a limited supply allocation. And we recognize that it's a very difficult situation to handle at the country level, because normally for many other vaccines, new vaccines, introductions happen at the national level immediately from the start. I think there are only a few examples where a subnational introduction has been done. And so I think it's very important for each country to think through the pros and cons of starting with a subnational introduction with very limited amount of doses. Some countries, I think many countries with whom we've had interactions so far, see it as a potential opportunity to start relatively small in these highest need areas, to be able to learn lessons, have some experience with vaccine introduction, and then apply these lessons once more supply becomes available. Other countries may find it challenging because the need is so high in many areas, and may prefer to wait until more supply becomes available. So this is really a country level conversation and dialogue that needs to happen, and each country needs to find its own response to that issue.
Yes, and really that's the role of the country's NITAG to guide in that decision making. So there's one last question regarding cases where areas of low or no transmission, no cases. Should the vaccine become available? If the supply is not limited, should the children there be vaccinated? I think the question is, why are we limiting this to high transmission areas? Is it only about the supply, or is there something about the vaccine that it should be limited to moderate and high transmission zones?
Yeah, it's another good question. So it's actually interesting from the phase 3 trial that MacGyver showed some data. The efficacy was actually even higher in low transmission settings. For example, in Kilifi, I think had one of the highest efficacy levels. But of course, what counts in the end is the impact given the number of cases that can be prevented. And that's driven by the underlying burden. And when the phase 3 data was analyzed from a cost effectiveness point of view, it was found that the best cost effectiveness was indeed in areas of moderate to high transmission. And that if you go to very low transmission areas, the cost of the vaccine might be too high in the sense that your cost effectiveness becomes less attractive. So one could argue if we had a lot of supply and the vaccine was very, very cheap, it may also become cost effective in those low transmission settings. But unfortunately, at the moment, we are not quite there yet, both in terms of supply and cost.
All right, Benjamin.
Thanks, Celia. So I've got a question to Mugawa and also to Eliane. So for Mugawa, I think you showed a slide that looked at the RTS 001 coverage for dose 1, I think 2, 3, and 4, and alongside other routinely administered vaccines. And I think to me what was interesting is how much detailed that data was, because I think it was monthly data, which prospectively could even pinpoint the reasons behind drop in coverage. You know, you mentioned healthcare workers strike in Kenya, and also I think it was a cyclone in Malawi. And I'm wondering whether that level of details, you know, whatever system that was maybe put in place to collect that information could be expanded for use to other vaccines that are included in the EPI program, because as you know, with Immunization Agenda 2030, you know, one of the core objectives is to make sure that the program is data-driven. And in my opinion, that level of details in terms of immunization data is very useful to guide decision-making. So is this something that was put in place for these countries during the implementation? And is it something that can be expanded to other vaccines, Mugawa? And then to Eliane, the issue of equity that you mentioned, that some of the children who were reached during the implementation program were actually children who could not be reached with the malaria, seasonal malaria chemoprevention. And I want to get your views on whether that could also be an opportunity to, you know, reach out to zero dose and missed vaccines communities. Is there an opportunity for the malaria vaccine introduction to also reach out partly to some of these zero dose and missed vaccines communities? Thank you.
Chair, can I come in?
Yes, please.
Yeah, thank you, Ben, for a nice question and good observation. We receive this data monthly from the ministries of health. They share certain antigens that the malaria vaccines program is interested in. So we're asking for other TSS doses, the first, the second, the third, and the fourth. We also ask for other vaccines, in particular, Penta 3, so that we can compare the performance of RTSS to Penta-3, in particular, the first doses of the vaccine of the vaccine. Are we getting to where Penta is? And Penta is regarded as the proxy of the performance of the EPI, programs, worldwide. So we want to compare with the standard. We also ask for measles, rubella 1 and 2 for the same reason. Some of the doses for RTSS are given during the second year of life. And we want to compare with this vaccine, which is also 1 dose is given during the second year of life, to see how we're doing compared to pre-existing, antigens that have been there for a long time, sort of established, well-established antigens within the EPI program. So really the congratulations, the commendation that you're giving should go to the Ministry of Health. All that we do is to support them. And I want to assure you that they have a system which captures, the coverage of all the antigens. It could be DPT, it could be hepatitis B, all the antigens, even those that you didn't see on those graphs. Of course, in terms of how the system is working, varies from country to country. There are countries that are doing very well. There are countries that have challenges, and they are working on those challenges. So I think I will take your commendation to the ministries of Ghana, Kenya, and Uganda, and the Malawi. Of course, they are doing quite a good job, to be honest. And they are, in terms, Afro classifies, immunization systems into categories. They rank to be in the 2 highest, the 3 countries, they rank to be in the 2 highest best performing categories. So yeah, that's the answer that I have, Ben. The systems are there. Some of them need to be improved so that they do a better job, like the one that you have seen for Malawi, Kenya, and Ghana. And WHO and partners are always available to support the countries to improve on such aspects. Over.
Okay, Eliana, you want to supplement that?
Yeah, maybe I can cover the second question, which was related to whether this vaccine provides an opportunity to reduce missed opportunities for vaccination or reach out to 0-dose children or missed communities. And I think definitely the answer is yes, because the vaccine schedule itself provides new opportunities, new touch points for parents and the children. So for example, in Kenya and Ghana, they've chosen a schedule of 6 months, 7 months, 9 months, and then 24 months for the 4th dose. And so some represent new visits. And each new visit, of course, is a little burden for the parents, but also once a child is presented, is an opportunity to check on previously missed vaccines, so that the infant vaccines can be complete, but also to administer other interventions, vitamin A, do growth monitoring, deworming, potentially a bed net if that's part of the national policy. And so that's an opportunity to increase coverage of other interventions and other vaccines if it's done deliberately. But it's also an opportunity more generally, because the vaccine or the malaria burden is so well known in the community that it is a possibility that the demand will be high at the facility level, and maybe some additional children are brought in because it's a malaria vaccine. And then I think it would be important that the training is provided to the health worker to make the best use of these opportunities. And there is the potential to reach unreached children. The missed communities and zero dose in general, I think by going to the highest need areas, as explained by Professor Rees, there will be some overlap of these highest need areas with areas where we have a lot of zero dose children. Because the greatest need is also a reflection of maybe access to care. And so there is an overlap in these areas. So that in itself presents an opportunity. And if at country level, there is a possibility to make increased efforts because it's a new vaccine and because it's a malaria vaccine, then maybe that gives some momentum to the efforts to reach missed communities and zero dose children. So we very much hope that these opportunities are being used and successfully implemented.
All right. I want to thank you very much, Magafo and Eliane, for your submissions, as well as Professor Rees in absentia. And I'd like to close this session at this time so that we'll give some time for Nish to inform us about the library guide. Over to you, Benjamin.
Thanks, Celia. Suzanne, do you want to share your slides and take us through the next session?
Yes, I will do that. Share.
And Suzanne, if you can spend the first half a minute to introduce yourself and show your face on video, that would be great. Thank you.
How do I do that? Okay. Ben?
Yeah. It's fine, Suzanne. I think maybe you don't have probably you're struggling to activate the video. It's fine. You can present. Go ahead, Suzanne. Thank you.
Okay. All right. Sorry about that. So yes, hello everyone. My name is Susanne and I'm a librarian for Niche. Librarians are known for their skills to identify, scope, plan, gather, evaluate, manage, and present information and resources related to specific topics and subjects. I'm going to give you a brief presentation on library guides in general and a library guide on the malaria vaccine RTSS in specific. So the outline of my little presentation is a short explanation of what library guides are, the aims of library guides, also the vision of Niche's specific library guides available at present for the Niche project. And then I'm going to show you what the malaria library guide looks like. So what are library guides in general? They are specifically created to assist researchers, such as you are, with accessing and understanding key resources for their subject area. Library guides also are tools to help users to navigate and access resources. Library guides provide a clear, organized layout of resources related to a particular topic, and in our case, it will be references to the malaria vaccine RTSS. To use library guides saves time and effort instead of searching and scrolling through numerous catalogs and websites. Library guides usually fit specific needs, such as ours at the moment, and can be tailored for specific projects. Library guides offer access to quality resources. This ensures that users have access to those resources. Library guides are multimodal and can include books, articles, videos, websites, as well as grey literature, maps, infographics, etc. Library guides can also facilitate collaboration among users and encourage group work. In summary, it is a valuable tool to help users save time and to access quality resources, and they are useful for particular subject areas or research in new and unfamiliar fields. The library guide's main aims in niche specifically are designed to access to contextually relevant evidence-based research to support policy decisions, to improve the capacity of NITEX in evidence-informed decision-making and giving access to resources for improved recommendations, and to support the work of the Sustainable Regional Scientific Hub for African NITEX specifically, and other users in Africa to high-quality evidence to inform vaccination policies, programs, and practices. Library guides also assist in training interventions to support information, findings and discoveries, and also to locate, to learn how to locate resources with skills and abilities. The vision for niche library guides they are intended as a service to NITEX, such as you are, to add evidence in the form of literature, be it published or unpublished. The filter that we are using are all African countries. It's specifically for Africa. The library guides are regularly updated with the latest articles that have been published. And several databases are used, and they will always be listed from which one we use them. By reading the abstract, for example, one also learns how to distinguish between relevant and irrelevant literature for the specific topic at the moment. So the current library guides for the niche project are, the first one we did was on COVID-19 and vaccine hesitancy or vaccine confidence and all African countries. And the second one is malaria and RTSS vaccination or vaccines in Africa. The ones which are still in the pipeline are HPV or human papillomavirus and vaccines in Africa. And another one would be routine childhood immunization and EPI and vaccine coverage in Africa in general. So those are in the making as we speak. So now I would like to show you the library guide on malaria. Can you see it? Am I still sharing?
No, Suzanne, we're only seeing your slides now.
Oh, so I have to go out and okay.
Share the browser.
Page.
Okay. Is that better?
Yes, we can see the LIB guide now.
Okay, so here's the library guide on vaccines. And as you can see, it consists of tabs up here, which are like table of contents. So whatever you would like to open up, it will be in one of these tabs. So if we open the Home tab, you will see a short introduction of the library guide. And one of the documents that we are using for this library guide was the March 22 WHO malaria position paper. And we extracted all the references that had been used for that position paper. And there's just a little bit of background here. And here you can see what happens if you search for RTSS vaccine in general, and what is available if you go through this library guide. We also have a few online open access books, which you can have a look at if you are looking for more general information, which are available through the library, through the UCT library. Here is the position paper. So this is what it looks like. And if you click on this link down here, it will open up the whole position paper on malaria. And these are the references extracted from the position paper. And they, as you can see, they're also available online if they are open access. If they are not open access, it will be indicated with a little not OA, standing for not open access. Should you still be interested to have a look at the full text of this article, called Malaria Infection and Severe Disease Risks in Africa, you are welcome to contact me and I will make an interlibrary loan for you from another library. The countries with the most incidences of malaria are Kenya and Ghana, and that's why they have extra tabs. And then what we also did is we used library databases, namely PubMed, EBSCOhost, Scopus, and Web of Science, to extract the most important and most relevant articles for specifically the malaria development and the RTSS vaccine that is in the making at the moment. We also have a few maps which we can have a look at, which are quite interesting, just to get an overview over the coverage in general. And we actually found 140 articles on that specific topic, but we extracted the most relevant ones, which is about 35. Yes, and it's the same principle. Here I've made another note of an article with the comment not open access means that it's not available with open access. You can contact me. This is my email address should you wish to read the full article. And these are the articles that we extracted. They are in alphabetical order, so you can have a look through those, and where possible, there is a link to the article in full text, which you then can open in the library guide. So that is all I have to say for today. If there are any questions, you are welcome to contact me.
Thank you so much, Suzanne. Greg, I see you've got your hand up. We're running out of time. If you can be quick, Greg, go ahead.
Yeah, very brief. Thanks, Ben. Very briefly, just to clarify, the last tab that looks at the RTS vaccine literature from those various sources, the literature looks specifically at vaccine efficacy, vaccine effectiveness, and vaccine impact. And as Suzanne says, there are about 35 publications that are available there. We did not look at the other articles that spoke about the development of the RTSS vaccine, but we thought the issue around efficacy, effectiveness, and impact would be of most use to NITAGs. And this is a work in progress. We still need to quality check the data and possibly add a few additional references. That's all, Ben. Thanks.
Thank you, Greg, for clarifying that. That is a very important point. Otherwise, it would be too wide. The whole topic would be too wide. So we did concentrate on the efficacy, efficiency, and impact of that specific vaccine. Thank you, Greg.
Thanks, Suzanne. I think we're running out of time. Thank you so much. If you can stop sharing your screen, Suzanne, I will share mine quickly. And just to quickly thank the speakers, Gawa, Eliane, Helen, and Suzanne, for your excellent talks, as well as your time and contribution to this webinar. And also to thank Celia from Uganda NITAG for moderating this webinar. Thank you very much. And also to thank WHO for co-hosting this webinar with us. And obviously for the participants who have made this webinar interactive, your questions and also your participation is very much welcome. Just to remind you that these webinar topics were selected based on the feedback that you gave us. If you remember in our last webinar, when we did the webinar 4, which was on HPV, we asked you to tell us which topics of interest you want to be included in the webinar series for 2023. And can you see my slide? Greg, can you see my slide?
Yes.
Yeah. So I wanted to end by sharing the feedback that you gave us. So you said malaria vaccine introduction in Africa was one of the priority topics that you wanted us to cover, and we've done that. So the next webinar series are going to focus on the other topics that you selected. So the one is conducting routine immunization during public health emergencies, and then the Hep B birth dose and novel polio vaccine. So thank you very much. And just to indicate that below here is the niche website, which was launched early this year in January. And if you visit this website, and the slides are going to be shared with you, you're going to find a tab that says Assets and Resources. Under that tab, you're going to find library guide. You're also going to find evidence gap maps, which visually shows evidence that is available on some specific areas related to vaccines and immunization. And this is very much focused on the continent. And you're also going to see data portal. So this is an area that we're trying to provide the data that may be relevant to NITAGs in their work to advise the ministries of health. So with that, thank you so much, everyone, and also to thank the niche team for making sure that this webinar happened in terms of preparation. Thank you so much. And look forward to seeing you in our next webinar. Wishing you a very good day. Thank you and bye-bye.
Thank you very much. Bye-bye.
Bye-bye.